Okay, so let me just recap here. In terms of spinal stenosis, just to go over the topic and just to make sure everyone's on the same page, spinal stenosis is usually from one of three things. It's usually if you're looking down the tunnel of the spine, you get severe joint arthritis. That thickened joint could squeeze the nerve tunnels. You can get a disc herniation. The disc herniation can push back, squeeze all the nerve tunnels, or you can get spondylolisthesis. All these bones sliding forward. It's usually L5S1 or L4 L5, and that squeezing, if you can imagine, it's almost like a window, kind of closing that window. If those are the nerve tunnels, it's squeezing like that, pulls all the nerve tunnels. That's the third type of what could cause spinal stenosis. Could other things such as infection, tumor, trauma cause it? Well, of course, those are all things that could cause spinal stenosis also. But usually, those three topics I mentioned are the main causes of spinal stenosis. In terms of how to cure it, it's really about curing it at that particular level. It's really about curing it. If you want to cure the whole spine, that'd be an entire spine fusion, decompressing the entire spine, fusing the entire spine so it doesn't come back. That's that's ludicrous. You don't need your entire spine fused unless you have like a big degenerative scoliosis. That's like a T tendon pelvis. That's a big surgery. That's these pedicle screws and all that. But say you have spinal stenosis, even with a little instability at one level or two levels. So you have tightness of the nerves just at one or two levels. Very likely, a spine surgeon could do something called a decompression surgery. I use the ultrasonic decompression tools. That's just instead of using a burr, like spins at 70,000 RPMs. I use this thing that vibrates, kind of melts away the bone. That's how I can do my decompressions, and I do that whether it's a one level or a million level one. But doing that would cure. I say cure in quotes the spinal stenosis at that level. Look, you could continue to get arthritis. These joints kind of rubbing here throughout your whole life, and that thickened tissue could again cause spinal stenosis, squeezing the nerves for sure. Not super common, honestly. You could also later in life. So again, imagine if I took out a little column of bone from the back here to open up the nerve tunnels. Okay, great. You could lose disc space here, just like you lose air in your tires. And then just like those medieval guillotines that come down and chop off your head, if you lost disc space here and that bone comes down, starts squeezing the nerve, then you could get foraminal stenosis and get a recurrence of stenosis. Yes. So when I say cure, I'm talking about cure at that point. The definitive fix, and I'm not saying you necessarily need to do this at that point, would be a one level, two level, however many levels are impacted fusion. That's where I'm gonna put one of these spacers right here. Just imagine, wish I could take this disc material out. Wish I could get this in there without breaking this bone. See if I use one of my smaller cages. So that'd be, bear with me. Okay. Not 100% perfect, but getting one of those spacers in there just like that, that keeps these nerve tunnels open. You can see how the nerve tunnels are open in the back. And then usually you place these pedicle screws in the back just like that. That stops any additional arthritis occurring at that level. So when someone gets like a lateral fusion, extreme lateral surgery, sorry, as I fiddle with this to get that into the correct position. Okay, so look, that spacer goes in there, so you can see how that opens up the nerve tunnels. And you have these pedicle screws to give it the extra fixation. Come on now. Actually, it probably worked a little better if I held them like that. There's extra fixation on the back. So not apples to apples, not 100% lining up, but you can kind of see how placing these spacers here open up these nerve tunnels. So if you lose all that disc space and it's totally squeezing those nerves, this is why we use these cages. They go in there and they hold open those nerve tunnels just like that. Additionally, these cages are kind of a wedge shape. It's called lordosis. You have 0 degrees, which is none, 6, 12, 15 degrees that curves the spine back, gives you this curvature back. And that's important. That puts your shoulders over your hip joints, which you want. You want your C7 kind of over your hip joints. C7 in terms of cervical spine, you want your neck over your hip joints. That way, when you're walking, you're not walking like this, having to pull your spine back all the time. That wears out your spine, that gives you back pain. That's why these lordotic, these curved cages are really beneficial. Like, look at this high-tech cage I have here. See how it's like this wedge shape that's bigger in the front than in the back? That's just what we're using a lot more now. Back in the day, we used cadaver bone. Back in the day, we used these things called back cages, BAK. If you're in your 70s, 80s, and you had a spinal fusion, that's what we used. And it was almost like a coil of metal we just shoved in there. We didn't appreciate spine biomechanics. We didn't have the AI tools, the technology to follow up. So having these cages that are curved kind of puts it back here, and that helps limit additional spine surgery, helps cure future spinal stenosis by protecting the rest of the spine. So can you cure spinal stenosis? Definitely at that one level, you can do laminectomies, microdiscectomies, fusions, disc replacements to take the pressure off the nerves. Definitely a cure. Can it come back? Through different reasons, could come back at that level. Could happen at other levels. It's like if I fix one tire in your car, the other tires could still get issues. Okay, with that, I know I've been talking for a good while. I'm going to go ahead and answer some specific questions to help people really understand some things. One of my favorite people who's always kind of jumping on, asking a lot of great questions. Is their name is Sunshine and Sparkles. It says, is there a difference between retrolisthesis and spondy? Well, spondy is a nickname for spondylolisthesis. That's where this bone kind of moves back and forth. Spondylolisthesis has 6 types in terms of what caused it, but it's described also in 2 types: anterolisthesis, so slipping forward, and that's not good, or retrolisthesis, and that's where it slips back. Retrolisthesis is okay. It's kind of a compensatory mechanism your body's doing to try to align your spine a little better. It's not terrible to have retrolisthesis. It'd be great not to have it, but it's okay. Anterolisthesis is an indication for a spinal fusion, but doesn't mean you need a fusion. It's an indication for one, but doesn't mean you have to get a fusion. That's where the bone slips forward. That's 6 types there's 6 types of spondylolisthesis. Most of them are either something called a pars fracture, my absolute favorite thing to treat, called isthmic spondylolisthesis. If you have anything, you can reach out, but that's where I really feel like I shine. That's where this bone, just like in this model here, is loose. And when that's loose, you lose some of the tension band in the back. More disc degeneration occurs because bone, disc, bone. More disc degeneration occurs here at the disc space. Comes down, squeezes the nerve, numbness and tingling down. That's something where you ask a lot of spine surgeons, what's the cure for that? Well, if it's an isthmic fracture, if it's this bone fracture back here, you could just do a laminectomy. That's an okay way that people used to do it. You could do a non-instrumented fusion. Not ideal, but that's how we used to do it. Most spine surgeons would agree. If you have a pars fracture in the back here and you're having surgical symptoms, weakness, legs giving out, numbness and tingling going down, that is where they'd recommend a fusion. Fusion could be one of many ways. It could be with or without these pedicle screws. I would recommend with. That's not too debating. And it'd be with or without one of these cages or spacers. Most modern day spine surgeons would agree you have better outcomes using these different types of cages in the disc space. Cages increase fusion rates. They increase restoration of something called lordosis, kind of curving the spine back. And they increase patient outcomes and decrease additional surgeries. And then there's different types of cages. So you can see here in my hand, try to hold my hand up like that, try to give you some context. I'm seeing if I can put it behind something. Just hold it just like that. You see I have 3 different types of cages in my hand. These all go into the same vertebral disc space. This is something called a TLIF cage, TLIF. It's placed from behind posteriorly, so it's all from the back. You have 1 incision in the back, or 2, however they want to do it, to place this in. You can also make an incision under the rib cage and place a lateral cage. Oh my gosh, look how much bigger this one is. Much better cage, but not everyone can get this. Not every surgeon is trained to use these cages. That's a great cage I like to use all the time. And then, again, when we're talking about posterior only cage, that's what many spine surgeons do. You can also get one of these big cages. Look how big and higher this cage is. Well, if you're looking, being like, oh my gosh, do I want a big cage? It'd be great. The bigger the cage is, the more surface area. So look, more surface area over the bone. So the less subsidence, the less it's almost like a snowshoe going through the snow. The bigger surface area, the better. If you compare this on this cage, it's fine. But if you can have this over it, my gosh, drop that one down. Look how much better that is. Higher fusion rates, more lordosis, more curvature, but you got to go through the front to place this cage. And that's great if you have a good vascular surgeon. Some places are in academic institutions big famous name academic institutions, and they have vascular surgeons, but their vascular surgeons maybe do, stents, they do other vascular blood work, AV shunts, all these other things, and their schedule is a little demanding. Maybe they're not financially incentivized to do anterior approach, and so they just do fewer of them, and they're maybe not as excited about doing them. The timeline's difficult for them. The spine surgeon doesn't want to find the same timeline to coordinate the vascular surgeon for this one case. They can just do it all from the other way. So there's a lot of reasons your spine surgeon might not like to go through the belly. They might give you a bunch of reasons, but at the end of the day, the vascular surgeon access is one of the biggest reasons. Um, Many doctors have a vascular surgeon. That's all they do is they go through the front. They place those. Don't place the cage where they get to the anterior approach there, and that's great. Fortunately, there are many communities in America. Dallas is one of them, where we have many, many, many good vascular surgeons. They're extremely high volume, and that's all they do. They do the case. It takes them like 15 minutes or 5 in some cases to get to that front of the disc space, and the spine surgeon does their work. So that's another great way to cure spinal stenosis if it's caused by something called like a pars fracture or even isthmic spondylolisthesis. Okay, with that, I'm going to get to a couple more questions. Um, Some of these are, can you do an ALIF at 4.5 with no rods? What's the outcome? You can do an ALIF at 4.5 with no rods. It'd be called like a standalone ALIF. That's not incredibly uncommon. It would be kind of similar to this. You have to have a special type of cage that has something called a standalone indication. So it's a cage like this that has either blades or screws that go through it. And then sometimes when I do a standalone, I'll put a plate over the front. 4.5, I don't always because the vessels cross over there. But you can do that without screws in the back. It's a little bit based on the indication. Look, I kind of say if you have instability like that, you should do screws in the back. If you have instability, that's an indication for a fusion. So it's kind of a narrow window of indications of why someone would get a fusion without screws in the back. Another question is, curious which pain management doctor in DFW you usually recommend, from Camille. Camille, if you direct message me, I'm happy to tell you based on where you live which pain management doctors I use. DFW is huge. Honestly, I have one of my good friends in the McKinney area. I have someone in the Waxahachie area. I have someone in Fort Worth. I have someone in Rockwall. I have like 3 in Carrollton, Plano. So there's probably 80 pain management doctors in Dallas. I consider myself work friends or colleagues with maybe 20 of them that I've sent over 50 patients to each of them, maybe some of them a couple hundred. So if you just reach out, I'll be happy to connect you with one of them, or just tell you who I'd recommend from that. But just let me know. Misha keeps asking, what is the success rate of the Intracept procedure? The Intracept's an interesting procedure. Pain doctor puts a needle in the back and does an ablation there. There's a doctor in Dallas named Heidi Lee. She's one of the Intracept specialists. In terms of the success rate, when it's done for the right indication, it's an extremely high success rate. Some people say they got it and didn't get any better. Well, they probably weren't a great candidate for it. From Nikki, said, I just had an ALIF Tuesday and woke up from surgery without any nerve pain in my leg. Yeah, that's extremely common. I tell patients all the time, like, your pain's gonna get better that day. Yeah, you're gonna have some back pain. It's gonna hurt. Your stomach's gonna hurt. There's stuff that's gonna be going on, but your leg pain, there's no reason it shouldn't be better that day. And that's great. That's why I like doing spine surgery. Is it's tough. It's stressful. It takes a lot of emotional energy. But you have so many patients that get better that day, and they're not the ones going on to chat rooms telling everyone about it. It's people that don't have good outcomes that are scaring other people away from it. So I really just encourage people to talk to people with happy outcomes, successful outcomes. So thanks for being vocal on that. It's really helpful to other people. A couple other things coming through is, will you work in the neck? Yep, I do surgeries in the neck all the time, cervical spine. That's kind of doing bone, disc, bone. You have different bones here when they're bone on bone collapse. You put in spacers that kind of open it up. This is an ACDF gauge. It's a lot smaller because your neck's a lot smaller, but this is another type of high-tech gauge. You can see it's almost like, I don't know if it's going to come through on the screen. It's almost like it's sandblasted, and that's nice. It's just with the newer technology we use. Let's see what I have some older. I don't really have any. Here's kind of an older technology. A lot of people use it, so I hate saying old like it's a bad thing. But you see here on this cage, these cages here, I don't know if it shows up that well, but they're like plastic. That's fine. That's called PEEK, PEEK, stands for like polyethylene something ketone, and it's the type of composition of these cages. While they're okay, they kind of simulate the same structure of bone, which is nice, the same hardness of bone. So there's advantages to that, but they don't stimulate bone growth. That's why I like certain titanium cages that have this kind of plastered, spray painted onto it. It stimulates bone growth. And I think that's a huge advantage of some of the newer technologies. If you're in your 60s, you've been doing it the same way your whole life, well, that's probably pretty outdated. There's a famous spine surgeon in Chicago that says if you're still doing spine surgery the same way you were trained, then you're outdated already, even 5 years after training. So it's always good to just keep evolving. That's, whatever profession you're in, think about the things you're doing now versus 5 or 10 years ago. And there's just a whole different litany of technologies we use. Okay, let me answer a couple more questions here. What are my thoughts on the Barricade device? I'm like the most diehard fan of it. I think there's certain financial benefits to an institution and even to the spine surgeon that might have them be using it maybe more than they should. My question on the Barricade device is, it's argued that you have less reherniation rates. Okay, fine, but it's also really damaging the end plates of the bone. There's two different studies that show that. And then if you have to do a revision surgery for any reason that's really scarred in, you have foreign material there. There's something called an A-lift in the future, or even a T-lift, and that's in the way, or even a lateral. You have this mesh device that's in the way they have kind of mess with, and it's pretty unusual for patients to have an operation for recurrent disc herniation. So to be putting in this implant for something that's simple like a microdiscectomy, to me, I'm just not there yet in my practice pattern. I'm not criticizing other doctors that do it. They probably truly believe they're helping patients. Again, appreciate all of the likes and shares coming through. That kind of helps promote this to other people. Where am I located in Texas? I'm in Dallas, Texas. Just as a reset, I'm a spine surgeon here in Dallas, Texas. Born and raised here, from here, so not going anywhere. My wife's from here, family's from here, so we're not moving. Fortunately, I mean, unfortunately, but maybe unfortunate for the other doctors here in Dallas, staying here forever. Okay, let me your own pain from surgeries. What's that question mean? Do you ever have your own pain from surgeries? I wonder what you mean by that. Do you mean sometimes my back hurt from surgeries? For sure, all the time. Do I take TRICARE or out of state? I take some TRICAREs. You just have to reach out to my office. Out of state, yep, all the time. My office, just reach out to us. We can show you how to set those up. I usually tell patients just direct message me, and my office will send you a template on how to do out of state or telemedicine referral. So you can just reach out to us. I can tell you that. But I don't want this to be an ad for myself. If you guys are curious, spine surgeon in Dallas, but I kind of want to move forward and talk about other things. What are your thoughts on Botox and the trap for 4 months after a PCDF? I'm okay with it. I don't ever do Botox myself or order Botox, but for muscle spasms, it's a good way to kind of help calm down certain muscle spasms for sure. Tiff, thanks for the follow. I appreciate it. A couple of questions here, and then I do have to run here. Thoughts on the Prestige LP? I think Prestige is fine. It's not one I use, but it's a fine one. What can be done for scoliosis in a 61-year-old female? Nothing. You don't maybe need to do anything. Probably the thing you might want to do is just see if it needs to be fixed or not. If it does, it's a pretty big surgery. It just depends on, is that scoliosis a one level fusion? Is it a T10 to pelvis fusion? There's just a whole range of different things that might be needed or not needed. How long do disc replacements last? Kind of forever. They don't really wear out. They're not like hip and knee replacements where those don't even wear out as much as those used to, but they don't really wear out. The biggest thing with cervical disc replacements, so I thought I had one here. These cervical disc replacements, the biggest issue that they have really is that they have a decently high rate of continuing your arthritic progression and fusing themselves together, and then it's a one level fusion. And that's okay. There's actually no clinical detriment if they fuse themselves together. And the rates are not low. In fact, to quote a certain study, it's from the Journal of Neurosurgery in 2020 or 2021. They had high impact 10-year follow up data on two level disc arthroplasties in the neck, and approximately 40% of the two levels had radiographic It's called HO, heterotropic ossification, where they kind of bridge bone here. That's not ever thought to be symptomatic. It's not thought to decrease patient outcomes. But so it's just one thing I just tell patients, like, it might fuse together in the future, and that's actually an okay problem to have. That's also why there's a whole conglomerate cohort, I should say, of spine surgeons out there that to treat spinal stenosis, they don't like using disc replacements because they say they fuse anyway, and that's not 100% inaccurate. It's just different practice patterns and different way people think about how to treat different conditions. Let me get to a couple more questions here. I don't want to say the name out loud because it's a patient of mine. So this person is saying we do not have any issues after my surgery, and I really appreciate that. And I've operated on this patient as well as their significant other, so it's kind of a family affair. That was another telemed patient, live here locally or in the state of Texas locally, and was able to take care of them. And really appreciate, it's very flattering not only to operate on someone, but then to also operate on one of their loved ones. And that's pretty darn common. That's a good way to kind of go about medicine. Couple more questions here, and then I do have to run. Let me just check one more thing right here. And I'll get to a couple more questions here, and then I do apologize, but I have to run. Got a couple things I need to get done. 30-year-old with L5-S1 grade 2 spondylolisthesis, severe bilateral neural compression from Crowbar. Crowbar, that's my favorite condition to treat. I encourage you to go to my YouTube channel. I have 20 videos just on that condition alone. That's when one bone is slipping forward on the other. I really kind of, in those videos, discuss why I love treating that condition, why I honestly believe I'm very good at treating that condition, and like what makes me good about that, and then why you even need that to be treated if you need to be treated. Grade 2 is no joke. That's a big slip. If you know the term grade 2, that probably means you've seen a spine surgeon for that already. Would love any opportunity to counsel you on it further, Crowbar. So thanks for asking about my favorite condition to treat. A couple other things from Raj, one of my longest followers, who always is asking great questions. Raj, love hearing from you, my good friend. Says, what has happened to me, doctor? I have severe joint pain now after my disc replacement and autofusion, so I do need a revision surgery. Raj, I'm not exactly sure. I would have to, I'd love any opportunity to ever see your images. I usually say I need a CT scan. That helps me see the facets on the back. That'd be one thing to do. I'm actually in the midst of treating one patient now who it's going to be it's kind of a tragic story in my opinion. He paid $100,000 to fly to a famous disc replacement doctor in LA, got a disc replacement, still having terrible back pain. I have a CT from before surgery, and I have a CT from 3 months after surgery, and the joints have more arthritis than probably any patient I'll see all year. No joke. Can't wait to show this case. And the reason that matters is, look, these disc replacements, here's a lumbar disc replacement right here. These disc replacements only fix this disc space here. So these disc replacements only fix the disc space. They don't do anything to these joints in the back. The facet joints in the back, these things that keep rubbing, those are unaffected by the disc replacements. So if you have severe joint arthritis, you're just going to make it worse. You're just going to keep rubbing them. They're just going to be terrible after the disc replacement. So you definitely don't want to do a disc replacement if you have severe joint arthritis. No way, no how. So I don't know. I don't know if the guy just missed it, but we'll just see. Stick around, and I can't wait to share the video and show you how we're going to get this guy better. So it's going to be a big deal, but relief is on the way, which is great. Raj, if you direct message me or if you go on some of my pinned videos, you'll see how to do telemeds. I know we've been talking for a couple of years now, so would love to take the next step with you. Another question from Brad, Dr. Brad. He had a micro in 2007, has deep leg pain again. Can you have another micro? Well, Brad, so that's an interesting thing. And that happens every now and then. Someone's like, oh, I had surgery before and now I'm in pain again. So the surgery failed. Well, man, that was almost 20 years ago. I don't know if I'd call that a failure. Not that you're not saying that at all, but they're like, I needed another surgery 10 years later, 20 years later. What happened? Look, you continue to get arthritis in your body. It's not like our bodies aren't necessarily made to last this long, but fortunately we have the tools and the abilities to make our body maybe last longer than they're always indicated to last. So that would be fantastic to take a look at that, and let's just take a look. You know, it's something where things wear out and things need fixes, and happy to be an option. Is a PARS defect present at birth from Marine Johnny? No, it can be. That's one of the 6 types. That's called congenital. And if it is, that slip gets to be really high grade. Those are where you see the spondyloptosis, which is like a grade 5, where this bone pretty much slips off of this bone. Huge deal, as you can imagine. And those present usually in your late teens or your 20s. That's where kind of this bone slips forward just like that and kind of way falling off. Those usually frequently are presented as grade 3, grade 4. Pretty big deal. But that's not an amazing, that's not an amazing, sorry, that's not a super common presentation or a super common pathology. So I was reading such a nice comment from Gretchen. Gretchen saying, amazing surgeon. You did my husband's back surgery. He's now pain free. Gretchen, I appreciate that. You sharing the good gospel kind of helps other people, maybe in different cities or different regions here in America. Hopefully, find a really good doctor who cares about them and a good, ethical, helpful doctor. So I appreciate that. A couple more questions here, and then I do have to run. Probably gonna run here at a 2:40, and then I'll probably stop my YouTube feed, but then continue on TikTok to answer a couple questions that I'll jokingly say are off the record because YouTube's of course recording me, whereas TikTok's not. A couple other questions. I have a spinal tap tomorrow. Should I be worried? I'd be curious why you're having a spinal tap. That's usually from infection or something bigger there. So why are you having a spinal tap? A couple more questions, and then I have to go, and I'll jump right back on. So let me kind of get to those. Again, my background is I'm a spine surgeon here in Dallas, Texas. If you want to reach out, you can reach out. Sometimes in the comments I see them, but you can always reach out to the office. You can always email us. I always say the number one thing patients need are both X-rays and MRI. If they have those, then we can do telemed, no problem. Looking at a couple more things from a couple more people. I think I'm actually probably going to go ahead and sign off now. Been going on strong here for about 26 minutes. Hopefully, I got to answer a lot of questions, but it's a nice Sunday afternoon. I kind of want to get back to some family stuff. Cowboys are getting crushed, which I'm used to. They can't hurt me anymore. And but I'm going to go ahead and sign off, and I just want to kind of connect with some of y'all people. So good to see you. Reach out for more stuff and go ahead and subscribe. And so for those on